My name is Dr. Barbara Melosky. I'm a medical oncologist at the Vancouver Cancer Agency, British Columbia Cancer Agency in Vancouver. First-line setting, we actually have two choices for EGFR mutation positive patients, and one of them is gefitinib, which we've been using for many years, and afatinib, which we've been using for a couple of years as well. And I think with the recent data showing an overall survival advantage with the 19 deletion, I think that's pretty clear. Most of us would look at that mutation and offer afatinib. I think there's still a role for gefitinib in some patients who are elderly, those who have difficulty communicating, those who can't really express, the side effect profile or be able to call into the cancer agency. So I think there's still a role for both drugs and an option for both drugs, but I think for the 19 deletion, the story is quite clear. LUX-Lung 7 is a direct comparison of gefitinib versus afatinib. This is a phase 2b, which means it was a sort of an exploratory analysis, but really patients were randomized either to gefitinib or afatinib and stratified for the mutation type. And this was a real, I think, a real effort of BI. We rarely see trials that are direct comparisons, so I think hats off to them. I think many companies are not that daring, or they don't want to put themselves out there, and I think BI did, and I think that it's a success story. So gefitinib and erlotinib are first generation EGFR TKIs, and they're quite comparable. So I think this is really a study. LUX-Lung 7 is really a study or a trial looking at a first generation TKI versus a second generation TKI. So I think it's really the very sort of the best comparison, especially in Canada, where those are our two choices. A head-to-head trial really gives the oncologist or the treating physician the ability to look at the data and really know which drug really is superior. Many of us do cross-trial comparisons, and they're sometimes done at different times, different parts of the world, different performance status. So I think with a head-to-head trial, all of those are controlled for. The result of LUX-Lung 7 showing an improvement in progression-free survival, which is statistically significant for afatinib versus gefitinib, I think was almost expected. We know that the second generation or pan-HER inhibitors are irreversible inhibitors at the ATP domain. So there's reasons why it should have been better, and I think that it panned out. I think that the hazard ratio 0.73, which was significantly significant, shows it to be the superior TKI. I think it's a really interesting curve. The progression-free survival almost separate at the median. And I think it could probably be explained by the resistant mutations that exist that we know about. So afatinib does have some T790 inhibition, and you can think that perhaps both drugs are working equally, but then as one acquires a resistant mutation like T790, then the afatinib shows itself to be superior. So I think it probably makes sense that they separate around that period of time. Well, again, I think the response rate being higher in the afatinib arm statistically is, again, another sign that this is a positive trial. And I don't think it surprises myself. We knew this, and I think now this trial actually proves it. Not really, but I think it's exciting. I look forward to seeing the overall survival, especially in the 19 deletion. So when we use drugs like afatinib or gefitinib in our EGFR mutation-positive populations, we often continue them despite signs of progression. So we continue them until there's lack of clinical benefit. So time to treatment failure actually is the time a patient is on drug where the oncologist decides it's time to move or to change to a different therapy. So time to treatment failure is a clinically meaningful endpoint in the practicing community. Well, this is, I think quality of life is always important. We have to always remind ourselves that this is still a incurable disease. This is still palliative. We want our patients to not only live the longest they can, but with the highest quality of life. So that remains still a very important endpoint. Well, I think that's interesting. We always assumed that, afatinib is a harder drug than gefitinib. Many of us have been using gefitinib for ages. And I think it's important to remember that there is only one dose. You can't dose reduce, where afatinib you can. So I was a bit surprised by those results, that the adverse events were very similar. And I think it just shows us that with time and with practice and, with education of using afatinib, that we can make it very tolerable. Well, the major strength again of LUX-Lung 7 is that it's a direct comparison. Patients are stratified per the type of mutation. It's done in equal population, and it is a positive trial. The main take-home lesson, or the main take-home message, is that afatinib is the superior TKI if one wants to achieve an increase in progression-free survival and hopefully overall survival and maintain quality of life. Yes and no. I think I've been using the 19 deletion as a reason to use patients on afatinib, and the 21 mutation has always been a question since we saw the results of LUX-Lung 3 and 6, where chemotherapy really was equal in the overall survival. It wasn't statistically different. And I think LUX-Lung 7 showing that afatinib is better than in that 21-point mutation. I think that's really interesting. That's the harder mutation, and it always been my theory that that's where a superior drug is needed, or for the harder mutation. And I think it shows that with the response rates.